Hello everyone, I'm Dr. Makarand. I work as a senior resident in the Department of Psychiatry in NIMHANS. The topic for today's discussion is schizophrenia and bipolar affective disorder. And what we shall be focusing on is the identification and management of psychosis and mania. And a small part of the presentation is also about management of the related emergencies. The very first thing that we will know about is how to identify psychosis. So psychosis basically is a disorder of thought and perception, right? So the core symptoms involve hallucination, which are abnormal perceptions, and delusion, which is a disorder of thought, right? So when we say hallucination, what exactly it means is it's a perception without a stimulus. And what it includes is abnormal perceptions, which happen when a person is clearly conscious. So they can also happen when a person is under intoxication or when a person is about to sleep or just waking up from sleep, so half asleep, half awake state. Those are not necessarily pathological, not necessarily psychotic in nature, right? What we are talking about is perception which happens in the absence of a stimulus and when a person is clearly conscious, right? And the most common hallucinations which are present in psychosis are auditory hallucination. Hallucinations in other modality can also happen in psychosis, but when they do happen, especially when visual hallucinations happen, what one has to be very careful is, are we looking at something that has an organic etiology? The second important component of psychosis is delusions, which are false beliefs which are not in keeping with a person's socio-cultural background and have morbid origins. So let's break the definition and understand what exactly it is. So when we say it's not in keeping with a person's socio-cultural background, it means that any other person who has a similar background, be it educationally, be it religious, cultural, right? He or she will not agree with the explanation that this person gives, right? And it has morbid origins. When we say morbid origin, is the explanation that a person gives to say why he believes in a particular thing. For example, if he believes that someone is talking about him, and the explanation that he gives why he believes so, it may be because he has hallucinations and that's why he thinks that people are talking about him. Or he may say that I come to know from the expressions that they make, or I came to know because that person wore a particular dress, right? So these are illogical explanations. These are called as morbid explanations. And those are characteristic of delusions. And the most common delusions that people might express is delusions of persecution. So what could be the other markers of psychosis? So when a person is not openly talking about hallucinations or delusions, right? When we say that a person is guarded about his symptoms, they may not openly reveal about it because in the past, when they would have talked about it, people would have not believed them, obviously, right? So they may not come forth and discuss about these symptoms. So there are some other markers which may help you understand that there's an underlying psychosis that may be there. So hallucinatory behavior. So people would have observed them talking or just making some gestures as if they're interacting with someone, when actually there is no one present with whom they should interact. That is called as hallucinatory behavior. And that is happening because they're responding to the voices that they're hearing, right? Then there is irrelevant, incoherent speech. So there could be multiple reasons why a person's speech, what I mean by this is when they talk, people are not able to make sense of what they're talking. So this could be because they're talking to the voices actually and responding to them. That's why people feel it is out of context. Or other abnormality that can happen in psychosis also is, or schizophrenia specifically, is something called as disorganized speech. In that, the organization of thought goes haywire. So there is no logical connection between subsequent ideas. So speech seems illogical. They seem to be jumping from one topic to another, right? And it makes no sense to the person who's listening. So that is when you come across irrelevant or incoherent speech. They're hyper vigilant. As we said that, the most common delusions that people in psychosis experience is delusion of reference and delusion of persecution, which makes them very suspicious, which makes them very vigilant. So when they are in an interview, every single stimulus or every single distraction, they'll start looking around, right? And they'll have that suspicious, perplexed look on their face. That's classical of hypervigilance. Unprovoked aggression. So this is another classical feature of psychosis, where aggression seems to be for apparently no reason. So usually if person gets irritable or there is a reason and then he starts becoming irritable and aggressive, this can be called as aggression. But when it happens without any reason, it is called as unprovoked aggression. So that is another classical feature of psychosis, where family members usually will come and complain that he suddenly comes and hits someone, right? So it could either be because of some hallucination and he's acting out on the commands that he's hearing, or it could be just simply as a part of disorganization, where we said that there is no logic or no meaning to what they are doing. Similar symptoms can be inappropriate laughter, smiling, and the reasons can be similar, and illogical, inconsistent responses. So it's not just hallucinations and delusions which are psychotic symptoms. Even these can be considered as other signs of psychosis. Coming to mania, right? So first we saw was psychosis, now coming to mania. So we must understand that both of them, psychosis, mania, will come in the later part of this presentation. Why we have chosen psychosis and mania? Because one thing is both are what are called as severe mental illnesses. Secondly, a lot of symptoms overlap. What are these symptoms which overlap? We'll come shortly to. Before that, let's understand what mania exactly is, right? So mania, the first symptom or the core symptom of mania should be either elevated mood or irritable mood. One may ask me, how is it different from normal mood fluctuations? We all experience happiness. We all feel elevated at times. We all get irritable at times, right? But what happens in any mood disorder, specifically mania or bipolar, is that these are pervasive mood changes. For example, when I feel happy, something good happens. I buy a new car, for example. I feel happy on day one. I feel happy on day two. But by the end of first week, my happiness, which was here, has gradually come here. This new car is still new, but I'm not so excited. So be it any stimulus, even if the stimulus remains, after some time, the emotional reaction, whatever it was, starts coming down, right? But in mania, that high may still remain like that for many days, for many weeks. So it is this sustained mood change, which is very, very important. It's not just the mood change, which is a natural phenomenon, but it's a sustained mood change that you're looking at. So it is either elevated mood, which remains high, or irritable mood, which remains like that for many days, many weeks. And that's when we call it as a manic symptom. And this may be without any trigger. And often associated with elevated or irritable mood is another core symptom, that is increased energy level. Why I'm telling them as core symptoms are because it is based on these two symptoms that you define mania. All other symptoms are secondary. They just are associated symptoms. But it is to diagnose someone as mania, you need to have these two symptoms. If there are other symptoms, and in the absence of these symptoms, they don't carry much value. They may just give you a hint that he may be having mania, but to diagnose someone having mania, you need to have increased energy levels or elevated irritable mood. So increased energy levels, how does it manifest? How does it clinically come to you? So there'll be increased activity levels, and the person will not get tired. He will be doing activities more than usual. In the speed may be more, and the person will not get tired. Usually he may get tired after doing 2 or 3 hours of continuous work. Here he can go sustain himself for longer periods. There is increased speech output with pressure. By pressure, I mean when the person starts talking, if you try to stop him, it's very difficult to stop him. He has this thing to go on and on. This decreased need for sleep. Again, what I mean by decreased need for sleep is they'll sleep for lesser duration and yet be energetic throughout the day. They don't feel drowsy later or don't feel the need to go back and sleep. Usually, if a person has slept for 2-3 hours, he will complain that I couldn't sleep well. But in this case, just a few hours of sleep is enough for them to regenerate. And there is subjective feeling of increased power, increased energy, increased stamina. Sometimes a person, not sometimes, quite often the person on asking by himself say that yes, he feels that there is a lot of power, a lot of energy that he's experiencing with it. So that is about increased energy levels. Associated symptoms are increased sense of well-being, self-esteem increases, they become very confident, they start making tall claims that I can do this, I can do that, start talking about big things, big plans. grandiose delusions, and very naturally this can also lead to increased risk-taking behaviors. You see that grandiose delusion has come here also. So we saw that in schizophrenia also we talked about grandiose delusions. So as I was saying, there are some symptoms which might be common. So mania can come with psychotic symptoms, and grandiose delusions can be one of them. Even persecutory delusions can be one of them. They can happen like because they think that they are so great, people are against them, and that's how the delusion of persecution may arise. So they have this increased risk-taking behaviors. Their perception of risk in any given task decreases, as a result of which they start engaging in a lot of risk-taking behaviors. Disinhibition, like singing, dancing. A very common example that we do use in our clinic to elicit disinhibition is we ask the person to sing or dance. In a normal circumstance, no one would do that. People would feel hesitant and shy. Even if they're good singers, they'll be a little hesitant to sing during an interview or while talking to people in public, unless it's a stage show. But with mania, because of disinhibition, they, even with a slight prodding, they may start singing, dancing. There is disrobing that can happen in some occasions. So that is about disinhibition. And another important feature, which is very, very classical of mood disorders, is affective lability. What is affective lability is there are sudden and extreme changes in mood. So at one point in the same interview, the person may be laughing, and in the same interview with some cue, he may become irritable or start crying. So there are sudden or abrupt changes, and these changes are of extreme nature. So these were the symptoms of mania. These will help you identify whether a person is in mania or not. But remember, what remains at the core is increased energy levels and elevated or irritable mood. There can be a lot of other features, like person may spend a lot of money, which is a part of risk-taking behaviors. There might be over-religiosity, where person suddenly starts engaging in a lot of religious rituals, doing puja, going to temples, which he may not do when he's not in a manic phase, or even if he does during his remission, it will be excessive. Okay, I was talking about these features, that there can be some overlapping features in both these syndromes. So there can be psychosis with mood symptoms. So irritability is another component, another symptom rather, that is very, very common in psychosis. So because of the delusions that they have, they are prone to get very, very irritable, right? But what is different in this irritability and the irritability that we saw in mania is the irritability is circumscribed. It is in the context of their psychotic symptoms, it is towards specific people, and it may not be long lasting. Mania, it is pervasive, it is long lasting, it is over random issues, it is over non-specific triggers, as opposed to psychosis where it is with specific triggers. So irritability is also a symptom in psychosis, but it's really different from how it is in mania, and this is how you differentiate the two. Mania with psychotic symptoms. So person with mania can also have, as I said, delusions of persecution, delusions of grandiosity. And how do you differentiate the two is differentiate delusions that happen in schizophrenia versus delusions that happen in mania. In schizophrenia or psychosis, when these delusions occur, they are very well systematized. They're very elaborate. So what I mean by them is there are multiple delusions and they all seem to be very logically connected to each other. In mania, on the other hand, these may be fleeting. They may not be so well organized. They may not be so logically connected to each other, may not be so elaborate, so not so detailed, not so fixed as it is in psychosis. So they may be more of fleeting, fragmented kinds. And when you start treating, it is the psychotic symptoms which come down first, and mood symptoms may resolve later. And in fact, if you feel that psychotic symptoms are prominent, they are also quite elaborate, fixed, you may actually consider a diagnosis something called as schizoaffective, where both psychotic and mood symptoms are prominent. I have made a special comment that's called as acute polymorphic psychosis. That is a condition which is more common than schizophrenia and bipolar, and sometimes bipolar can start as acute polymorphic psychosis. It is a condition in which there is acute onset behavioral changes, and there are both psychotic symptoms, mood symptoms in this condition. But what is important is the word polymorphic over here. So they are fluctuating symptoms, intensity, the duration, the nature of these symptoms are quite fluctuating. and it's a short-lasting episode. That's why acute. But it has both psychotic and mood symptoms. So whenever a person presents with psychotic symptoms, manic symptoms, before diagnosing it as functional psychosis or bipolar, one must always be aware that a person can come with similar presentation, even if there's a physical cause, if there is a pathology in the brain. That's what I mean. Like there is post-head injury, post-fever, or during a febrile episode, if there is meningitis, encephalitis, convulsions, post-ictal, there's something called as post-ictal psychosis or or ictal psychosis, right? So convulsions also can be associated with these kind of syndromes. So one has to rule out all these factors: head injury, fever, convulsions, any focal neurological deficits, prolonged headache, which could all point that there is some other etiology also which needs to be looked into. Substance use, if there is history of cannabis use, alcohol use, any stimulants, which can also create a similar picture. So before calling it as a functional origin, we need to rule out organicity and substance use. If these things are there, but it is not necessary that in the presence of fever, if there is psychosis, it means that it has, the suspicion should be high, but there's not a 100% guarantee that fever or the infectious cause only has led to psychosis. There could be two independent events. So what will help you understand that a given factor like head injury or fever is causing a particular syndrome of psychosis or mania are three important things. One is temporal correlation. So only after the injury happened or after the event has happened, these symptoms have started. So only the etiological agent event has to happen first. After that, the symptoms should start. This is very easy to understand. Second is very, very important: known etiopathogenesis. So a given injury, a given lesion should be known to cause a particular syndrome. Just because there is a lesion and then there is psychosis or mania doesn't mean that that lesion has caused psychosis or mania. That lesion should be known to cause those kind of syndrome. For example, a lesion in the frontal lobe or the medial temporal lobe can explain psychotic or mood symptoms. But a lesion in the medulla or occipital lobe, unlikely to cause psychosis or mania. So the lesion may have happened a few weeks before psychosis or manic symptoms have emerged. But if the lesion is in some area like occipital lobe or medulla oblongata, that may not explain psychotic or manic symptoms. If it is there in the frontal temporal lobe, yes, it may explain. And treatment of the underlying cause. So if it is really due to that lesion, you treat that lesion and these symptoms also should resolve. So these three factors will help you understand if there is an etiological association between the lesion and psychosis or manic syndrome. So having seen how we can diagnose psychosis and mania, let's learn a few principles of the management of psychosis and mania. When it comes to psychosis, there are two phases: acute phase and maintenance phase. Commonly, what we use nowadays is second generation antipsychotics because of the side effect profile: risperidone, olanzapine. And among the first generation antipsychotics, haloperidol, chlorpromazine are commonly used. Often in the acute phase, what we may also require, as we said, is the person may have sleep disturbances, may be a little agitated, irritable. So what will also help the person calm down a little is an extra dose of benzodiazepines along with antipsychotics. In the maintenance phase, one can continue with antipsychotics, can taper off benzodiazepines after a few weeks. And even antipsychotics, the dose may be reduced. The dose that is required to control the acute phase is on the higher side. And for the maintenance phase, it may not be necessary to continue on the higher dose. So let's see what are the common adverse effects of antipsychotic group of drugs. So extrapyramidal side effects like tremors, they're more of postural tremors, unlike cerebellar tremors. Rigidity, which is more cogwheel type. Akathisia, dystonia. Dystonia is more of an acute side effect and can be treated with injection promethazine. It's an anticholinergic agent. Most common treatment options for EPS or extrapyramidal side effects are reducing the dose and adding an anticholinergic agent like trihexyphenidyl. Neuroleptic malignant syndrome is an idiosyncratic reaction. Most common, it is seen with first generation antipsychotics, less common with second generation. Even EPS are more common with first generation antipsychotics like haloperidol, chlorpromazine, trifluoperazine. NMS is characterized by rigidity, delirium, autonomic disturbances. Treatment is mostly used stop the offending agent. There is no way you can re-challenge with the same drug. Symptomatic management. You may need ICU care. And bromocriptine is one agent which can be tried in controlling NMS. Another important side effect of antipsychotics, especially the first generation antipsychotics, is hyperprolactinemia. The symptoms could be like decreased libido, irregular menses in females, along with oligomenorrhea, amenorrhea. There are some metabolic side effects which are mostly long-term side effects, and they're more common with second generation antipsychotics, especially like olanzapine, clozapine, quetiapine. Less common with risperidone, though it's a second generation antipsychotic. It causes lesser metabolic side effects as compared to olanzapine. What are these? Weight gain, dyslipidemia, hyperglycemia, diabetes. Coming to the management of mania, acute phase usually requires a combination of both mood stabilizer and antipsychotic. One may choose to treat with mood stabilizer alone, but must remember that it may take a little longer. It may take a few weeks. And a person who's very agitated, very aggressive, you may not want to wait for weeks for the mood stabilizer to act. So you usually combine mood stabilizer with an antipsychotic that reduces the duration of the episode. So the person shows response much faster than with mood stabilizer alone. In the maintenance phase, after a period of 6 months, one may attempt to gradually decrease antipsychotic dose, but continue on mood stabilizer. Mood stabilizers commonly use a lithium, valproate, and carbamazepine. Coming to the adverse effects that one needs to be careful while using lithium, valproate, carbamazepine. For want of time, I've included only the serious and important adverse effects. The common adverse effects, students can refer standard textbooks of pharmacology or psychopharmacology. In acute toxicity, acute poisoning of lithium, what are more common are GI side effects, gastrointestinal side effects, because that's the first system which gets exposed to the overdose of lithium. Neurological symptoms also are common, and those are like coarse tremors, not fine tremors. Fine tremors are more common in chronic poisoning, as you can see. But when fine tremors become coarse tremors, that's a sign of impending toxicity. Ataxia, nystagmus, hyperreflexia, convulsions, coma can also happen in cases of lithium toxicity, acute toxicity. In terms of chronic poisoning, there's cognitive dulling, which is a very common side effect patients complain of. Hypothyroidism, renal toxicity. Apart from this, it also has side effects like weight gain, acne, even hyperparathyroidism, but I've focused only on the ones which we commonly monitor. Coming to valproate, valproate has a lot of common side effects like gastrointestinal distress, nausea, vomiting, skin changes, acne, alopecia. But what I focused are three important ones which are serious, and they are black box warnings from the FDA: hepatic failure, pancreatitis, and encephalopathy, hyperammonemic encephalopathy, especially in people with urea cycle disorders. Coming to carbamazepine, carbamazepine again has three serious adverse reactions. One is hyponatremia. I'm sorry for the spelling mistake there. Agranulocytosis, and dermatological reactions. Apart from that, there can be sedation, mild dizziness, ataxia. Coming to the last part of the presentation is emergencies. The main emergency that one may face while handling patients with psychosis and mania is aggression, right? And before coming to pharmacological interventions, I want you all to focus on these two things. One is security alarm systems. Always when dealing with aggressive patients, you should ensure your safety. And one way of ensuring safety is ensuring that you're not interviewing them alone. You have few people with you, especially security guards. Your alarm systems in the casualty are intact. So the moment you feel there is a need or there is a risk that someone may harm you, you need to use the alarm system. Having ensured your own safety, and other important things are when you interview aggressive patients, always ensure that you are not showing your back to the wall. You should be standing close to the exit. So in case if things go out of hand and person gets aggressive, your exit should be easier. So that is another important thing that one must remember while dealing with aggressive patients. Next, what I mentioned is verbal de-escalation techniques. So these are techniques basically while talking to patients who are aggressive or on the verge of rather getting aggressive, because person who is aggressive, you may not want to talk to him. It may not be easy to talk to them. So, but when there is impending aggression, these techniques are very helpful. These include when you talk to them, you maintaining a very calm, a composed tone, not either standing over them. You should maintain eye contact and interact with them face to face rather than them sitting and you standing, which they may perceive as very threatening. Can encourage them to eat food, drink water, asking them that this may calm them down, and never confront them as to why they are angry. Try to understand or try to validate what they are feeling. You can use sentences like, I understand that you are feeling very angry or feeling very upset, and I want to understand what we can do to help you. Confronting them or telling them this is not right may actually, or getting into arguments with them can worsen things. So these are few techniques that you can use to what is called as use verbal de-escalation in dealing with aggressive patients. Coming to pharmacological interventions, when these things fail and person gets aggressive, what you can use is some injections, IM or IV. Most centers use intramuscular preparations, haloperidol, olanzapine, even aripiprazole is available. When using haloperidol, remember that, especially if you're using it IV, QTC prolongation is a very, very important side effect that you must monitor. So any person who has any comorbid cardiac condition, be very careful while using haloperidol. And if you're using it, do check the QTC. And in case of repeated doses, continue monitoring QTC. Coming to benzodiazepine, another option of dealing with when seeing agitated patients is using benzodiazepines like lorazepam, midazolam. What is recommended is a combination of both antipsychotic and benzodiazepine. The combination that we use commonly in our center is haloperidol, lorazepam. There are several advantages of using this combination. One thing is when you use both of them together, the actual dose of antipsychotic required to calm a patient reduces. The sedation is for a longer period. Rates of EPS also are longer. And lorazepam also augments haloperidol's antipsychotic properties. So there are multiple advantages of using this combination together. And even if these take some time for the patient to settle, one can always use physical restraints. But when you use physical restraints, ensure that you are monitoring the vitals regularly, ensure that you're checking the circulation in all the limbs. And as soon as you feel that person has settled, is sedated, you need to remove the restraints. Every 10 to 15 minutes, you all must monitor for all these things when physical restraints are being applied. And as soon as possible, you must remove the physical restraints. So yeah, so monitor vitals when you are using sedation, ECG for haloperidol. Always be aware of medical comorbidities and substance use. When dealing with aggressive patients, know that it could be either because of intoxication, withdrawal. So coming back to the same point that it's not just management of the aggression, but also understanding. So if a person is in withdrawal state, treating the withdrawal state itself can help manage the aggression. That is all I have to say about identification, management of psychosis and mania. Thank you.